Okay, so our next speaker is gonna tell us, how to. It's about stress. No, depression. Depression is a major problem in mental health. And then during intervention, we need to see whether intervention works or not. How to assess the intervention. So the next speaker gonna talk about how to use a simple Fitbit to do that.
Hello, my name is Chinmaey Shende. I am a PhD candidate at the University of Connecticut. I'll be presenting my paper, predicting symptom improvement during depression treatment using sleep sensory data. Depression is a widespread and serious illness. In current base practice of clinicians, depression treatment is mainly involves the closely monitoring the symptoms and adjusting the treatment as appropriate. However, monitoring the symptoms with help of the physicians and or using the self-report surveys, it is involves the high cost, it is burdensome and involves the recall bias. Therefore, there is urgent need to develop easy to use tool that can provide objective, timely, and accurate symptom monitoring. Now we have seen there are a lot of sensory techniques and devices that allow collecting the data very easily, and the methods can provide the data which is more objective, and it is very less burden on the patients for collecting the data. So our approach is focus is to use sleep sensory data collected from the wearable devices in this project. We chose to use only the simple sleep features such as a mean and standard deviation of the daily sleep for a period of a week. And the reason behind this is it is very easy to collect this data by using various different platforms, and these features are less affected by the sleep habits and the lifestyle of the individuals. So this is the high-level approach. We use the Fitbit to collect the sleep data from the participants, did the data pre-processing, then feature extraction, and train the classification model, which we use for the predicting the symptom outcomes, symptom improvement outcomes. In this study, we collected data from 28 depressed participants, out of which we had 26 female participants, 2 male participants. We recruited them from the various clinics, and the data was collected up to 12 weeks of participation duration. The clinicians performed the assessment, and they used the clinical global improvement, that is CGI, as a tool to report their assessment for the monthly interviews. And we use this for using the ground truth for our classification. By collecting this data, we were able to calculate, extract 220 weeks of samples, and which involves around 101 improved and 119 non-improved samples of the weekly data, weekly periods. Overall data for the participants is shown in this pie chart. So after doing the further analysis, we realized that there is significant amount of missing sleep data because patients were not were able to provide the sleep data consistently, and they had some technical issues as well. And we used the and the other issue was the data was highly dynamic and noisy, if you can see in the figure below. So we use the L1 trend filtering to obtain the sleep trends for the slower sleep trends for various durations. Regularization parameter lambda works as a penalty term to make the trends smoother. Larger the lambda, we get the smoother trends. In this diagram, I'm showing the time sequence starting from enrollment to the time of prediction of the prediction. So here we show the weekly features with mean and standard deviation of the sleep, and these features are shown how many weeks we are using the data for prediction, starting from like k equal to 1 week, k equal to 2 or 3 weeks. We also mark the baseline of the sleep data, weekly sleep data, at the week of the enrollment. However, we did not have all the participants wearing the Fitbit in the first week, or they started the enrollment slightly later. So we have approximate data for this. And so by using this data, we performed the systematic analysis of our prediction by looking at the features and the machine learning models. So we tried to analyze the impact of k weeks of sleep data, or including or excluding the baseline sleep features. And we trained the models, the SVM, XGBoost, and random forest. We use the leave one user cross validation to avoid overfitting because our data set is small. So I will just present the results for only using the sleep data, and we don't include any baseline in this case. We were able to obtain 0.66, the best F1 score, when we use 3 weeks of data and lambda equal to 200. And here we can see, using the simple sleep feature itself, we can already see we can get the reasonable F1 score for the prediction. Now I am presenting the results when we add the ground truth baseline, add the baseline sleep data, and here we can improve the, we could see the 0.66 F1 score was improved to 0.68 for 3 weeks. And when we look at the, when we look at the k equal to 1, we had the more significant improvement. The F1 score improved from 0.6 to 0.64. We understand that this is happening because by providing the baseline, we are able to provide additional information, additional insights, and it can be clearly seen when we look at the k equal to 1. So our conclusion is, conclusions are, we applied the trend filtering to noisy raw sleep sensory data, and to extract high-level sleep features. We trained machine learning model to predict the depression symptom improvement. We showed even the simple sleep features, we can achieve promising F1 score of 0.68. And in future, we plan to improve this prediction by using more detailed sleep features, such as stages and structure, which we can obtain by using the Fitbit and other sensory devices. And we can also try to improve by combining it with the other sensory data modalities. Thank you very much. I would like to take questions and.
Thank you.
Thank you.
We have time for questions.
Frankly speaking, I'm saying it is intuitive to use the sleep data to predict the depressions. So I'm curious about what kind of special designs you have made so that you can make a better performance compared to the state of art.
I'm sorry, last part I could not hear you.
Yeah, I'm curious about what kind of special design you have made, since I think you are using the traditional machine learning, and yes. I don't know what is the key technical designs you have made so that you can make a better performance compared to the state of art?
Mainly two parts. We were able to reduce the noisiness of the data by using L1 trend filtering, and we use the simple models for getting the for using this for training the machine learning models, and by using the multiple shuffling the data, that also helped us in terms of the time series analysis.
And how's the performance compared to the state of art?
This is not directly comparable to the state-of-art machine learning models, because we are using this as a clinical setup. Most of the existing setups are machine learning. Most of the studies they use the PHQ-9 or QIDS as a baseline. In our case, we use the clinical data that doctors told whether the person is improving or not improving compared to the original baseline. So, but still, we were able to achieve similar performance up to 0.68, which we found most of the existing models are able to obtain.
Okay, thank you.
Any question?
Sorry. So you looked at clinical depression, right?
Yeah.
So the clinical depression, for the diagnosis, at least the patient has to have 2 weeks of symptoms to be clinically
Yes, that
diagnosed.
is the main.
So, but you looked at the weekly
Yes.
trends. So how is it?
So actually, we worked with the clinician, Dr. Kamath, from UConn Health. So we tried to, the objective of this study is to try to reduce the duration for which the clinicians need to wait until we can predict their improvement. So we used this data. The clinicians continuously followed up like every month. They looked at the their data in terms of the quiz. We suggested the participants to fill the weekly survey as well. So clinicians observed the quiz surveys, and also they observed the patients every month.
So you looked at the improvement over time, or
Over
just
the time. Over the time of 3
improving
months.
week by week?
Yes, we observed the improvement week by week in terms of the quiz, which I can explain in, I have little more details in the poster in the behind.
So I'll be curious to know how.
Yes, certainly, because I could not include the quiz part in my presentation. It was less time for me.
So to me, it's actually not that intuitive to use chest sleep data. Like, why did you pick it? Like, what's the theory behind this whole thing? Like, I mean, depression is such a complex construct. If it was just sleep, then let's just ask, how did you sleep? And then we know your depression. It feels a bit like why?
Yeah, actually, sleep data is means there are a lot of papers which people were like, it is a bidirectional relationship, and we can clearly, although by using the sleep data we were not able to show very clearly, but
Right.
when we did the analysis of depressed patients alone, we could see that they have less amount of sleep. And other thing we see that we had larger correlation of the sleep data with the improvement of the patients. So when we analyze the actual sleep data mainly for the people who are depressed, so that is how we were able to extract the classification.
Okay, all right.
Thank you.
Okay, thank you. Let's thanks the speaker. Okay, next one is AutoGate. It's quite different. This one, finally, we do some video analysis. Well, using video to extract the gate features to assess a patient with anti-SAR risk. So speaker is Islam, right? Okay. Thank